AstraZeneca ATS Highlights Webcast. It's a huge pleasure for me to be here today with my colleague Dave Singh. My name is Richard Russell. I'm a clinical researcher at the University of Oxford and a practicing physician for Southern Healthcare in the south of England.
Thank you, Richard. Welcome to this ATS Webcast Highlight session. My name is Dave Singh. I'm a professor of clinical pharmacology and respiratory medicine working in the University of Manchester in the UK.
Today we're going to take you through some of the highlights of, as we've seen it, of the ATS this year that was held in Washington, DC over in America. We're going to talk to you through some COPD highlights and also some asthma highlights, and we'll have some opportunity for discussion, and we definitely want you to be asking our questions. You can see we're going to run through this in a fairly loose way, but hopefully we'll keep to time. And again, if there are other things you want us to cover, please do feel free to jot your questions down and send them to us. It is important, though, to understand, because this is a pharmaceutically sponsored event, that where discussions relate to medicinal products, we can only talk about licensed indications. If there's new science, we can talk certainly about the science, but we need to keep the compounds out of it. So if you feel we're missing something out, this is perhaps why we're doing it. These are our disclosures, fairly standard ones for Dave and myself. Certainly, speaking on Dave's behalf, we work with pharmaceutical industry because they help us educate people. They help us get out there and put this information in front of you, which is a great thing to be able to do. And before we start, just to, again, finally say, we're delighted you've come to join us at this virtual meeting. We're really excited to collect the information and then to give you this information. We definitely want your feedback. We want you to submit your questions throughout the meeting, so please do feel free, and we will try and address them directly and today. Thank you. So, Dave, you looked specifically at money that went to some of the COPD sessions and spoke at some of the COPD sessions. Tell me some of the highlights for you and talk me through your first subject, which is going to be about steroids maybe in COPD.
Yeah, okay. So I think we're going to touch on the FLAME study. Let me start with the pro-con debate session. As you know, and for those of you who are at the ATS, the pro-con debates have become a bigger and bigger forum to discuss issues that I debated with Visha, the pros and cons of inhaled steroids. I was pro. She was con, and much of it centered around the FLAME study. And there was a sub-analysis of the FLAME study shown at the ATS in those patients who had a history of 2 exacerbations in the last year, and the pattern for the main data was retained, that there was superiority for the dual bronchodilator over inhaled steroid beta agonist combination. And for most of the sub-analyses that are in the main paper and have subsequently been shown, that's true. If you look at any group, whether it's on age, gender, smoking history, you see the same pattern. The one area that came up in this pro-con debate where there is controversy, and I'll give you my belief and then I'll tell you what Visha thought about it, is when you look at the eosinophil count, and I think later on we'll go into eosinophils in much more depth. When you look at the main FLAME paper, they cut the eosinophils by 2%. And then you still see this superiority for the dual bronchodilator of about 17% for moderate to severe exacerbations. There's now a paper, Nicholas Roche is the first author, it's in the Blue Journal. When you look at an analysis splitting the groups into 3, so less than 150, 150 to 300 and 300 and above, then you see that for the group with the lowest eosinophil count, the effect size actually gets bigger. And these, to me, are the steroid non-responders. People with a low eosinophil count, there's very little or no effect of inhaled steroid. Then when you looked at the middle group, 150 to 300, and the high group, actually looking at the confidence intervals that go across 1. And you actually see, if you like, a concentration, blood eosinophil concentration response curve. So then you get into the debate about, well, if there is no difference between treatments, I'd rather give a dual bronchodilator because there's less side effects, etc. And my rebuttal to that was actually that for many patients, the side effects of inhaled steroids are actually low. There is this pneumonia signal, that's there. But if you look in the SUMMIT study, then and that was done in patients whose FEV1 was greater than 50%, there was absolutely no pneumonia signal. So we know that pneumonia is more likely in patients who are sicker. So patients with a lower FEV1.
And the elderly was the other big signal.
Yeah. Worse disease older. So patients who are younger, at an earlier stage of disease, you can safely prescribe inhaled steroids with regard to the pneumonia signal. The FLAME sub-analysis looks like about 2/3 of the population, the ICS-LABA is about the same as the dual bronchodilator. I'm sure Visha would say something else, and it's perhaps unfair she's not here to defend that. But anyway, that was the debate. And so I think it's becoming more complicated. It isn't a one-size-fits-all that FLAME tells us that dual bronchodilators are better than ICS-LABA, full stop. I think the effect is clearly dependent on the eosinophil signal. We then got into actually maybe this isn't the important debate. Maybe the important debate is within the context of triple, what's the benefit of the inhaled steroid component? Because there have been a couple of studies, there have been 3 studies now within the last year with a fixed triple therapy compared to their components, but none of them have addressed the fixed triple. And by triple, I mean ICS plus a long-acting muscarinic antagonist plus a long-acting beta agonist, all in one inhaler. The comparators have been ICS-LABA or LAMA, and for exacerbation, symptoms, lung function, the triple wins. So the bit that's missing is what's the benefit when you add on top of a dual bronchodilator. And those studies are ongoing. I suspect we'll see something, I'm guessing, later this year, early next year. I'll stick my neck out and say that there will be a signal, but it'll be eosinophil dependent.
Okay.
So those with higher eosinophil counts will get a benefit in terms of exacerbation reduction. Maybe we'll have one of these debates again and I'm right or wrong, we'll see.
Can I ask you something? Another slight subtlety about steroids, though. Was there any message about dosing of steroids and whether actually in the people who are sensitive to steroids, you can use a lower dose because that will also reduce the side effect profile of the pneumonia signal?
Yeah, so I would agree with that completely. There's no sense giving an excessive dose as the dose response curve. It's there, actually. Okay. It is there, but it reaches a maximum at something around 400 to 500 micrograms. Now, I'm not going to say beclomethasone equivalent because that's all, there's a certain complexity to that as well. But I don't think for whichever steroid you're using, you need to be up in the thousands. Okay. That's not necessary. All you're doing is, as you're alluding to, increasing the side effect profile.
Okay. All right. Anything else from the steroid front in COPD? Any other new signals?
No, not specifically. But I did look at a couple of the Salford lung study posters, and I found the Salford lung study very interesting in terms of the patient enrolled, and that was what one of the posters was around, and another poster was in terms of the level of symptoms. The Salford lung study, a real life study with very few inclusion criteria, and the number of exacerbations that you see in this population before the study and during the study is far higher than you get in the clinical trials that I've just been talking about, FLAME, SUMMIT. It's nearly 2 per year on average, whereas in FLAME, SUMMIT, the other studies, it's 1 or lower. So I think we're moving into an era now where hopefully we will see many more real-world studies of medicines, including inhaled steroids.
But the answers can be a little unclear sometimes from those things, and certainly Salford has got so much. There's a noise element to it, and there's a lot of uncontrolled element to it as well, but that's real life, I guess.
Yeah. So randomized controlled trials, they're beautiful for understanding the pharmacological effect of a drug because you control everything. You know that adherence is high. Certainly in the triple therapy studies I was involved with, we knew that adherence was 94%.
Wow.
But that's because the patients are being trained, we're monitoring it, and if they're not adherent, we call them in, and that's not real life. So there was an adherence poster from Richard Costello's group, and this paper, I think, again, is published in the Blue Journal fully. And this was fascinating. They measured adherence through an electronic device attached to the inhaler that measured, I think, the sound, and you would know then when the inhalation has been taken. There were some other adherence posters, and they used questionnaires where patients would report their adherence, and there are obvious flaws in that. This was very enlightening. And if you go and look at the paper, I'm not referring to the poster now. The patients are split more or less into three, and there's adherence and errors. So about 1/3 of the patients have good adherence and few errors. 1/3 have good adherence but errors, and 1/3 have poor adherence and errors. So it's only 1/3 are using their inhalers properly and adhering, and that's what the Salford Lung Study is testing.
And you can cluster those people actually, and then you can perhaps target your intervention a little bit. But you're going to need to pick it up, and we may get smarter with that. In the pro-con session, which was quite a lively session, but covered a lot. Was there any of the other debates which really grasped you as an observer as much as a participant?
Yeah, I enjoyed the final debate, which was on disease progression, and that was Christine Jenkins against Peter Barnes, and Christine went first and argued for being able to modulate disease progression, and she pointed out the effects of stopping smoking and the post-hoc analyses of uplift and of torch in subgroups or post-hoc, showing that all the classes that we use actually do in the long term reduce disease progression. Peter's point of view included the fact that these are post-hoc or secondary analyses, and therefore the case isn't proven. He said it rather stronger than that. He also, I think quite correctly, pointed out what a poor measure FEV1 is for measuring disease progression, and that early in disease we have abnormalities not detected by FEV1, small airway disease predominantly. And really, we need better tools for measuring disease progression longitudinally. So I think we then ended up in a situation where everyone recognised it's hard to measure it, but probably the drugs we have, although not proven as a primary endpoint, can prevent disease progression, but that we don't have the tools to get into early disease and measure it there.
So we still don't understand and can predict yet who's at high risk from the very beginning. All we can tell is they progress later on, and so
absolutely. And you mentioned from the very beginning that there was some data, not in the pro-con session, but posters from the spiromic study, and that's a reanalysis of more data from their New England Journal of Medicine paper, where they described some of the smokers who had normal FEV1, they have CT abnormalities. And there's that subgroup there who have symptoms, and some of them have exacerbations. And when you go officially from the gold management strategy and look at the diagnosis of COPD, because their spirometry is normal, you can't call these patients, these individuals, COPD patients. And yet they have symptoms and they have what you would call exacerbations. What do we call them? And one of the posters showed that on a repeat visit, that these patients still, more or less, displayed the same characteristics. There was some variation in their symptoms, but a subset were still having symptoms and exacerbations.
Is there an understanding of how to treat these people? Because at the moment, I think there was some data showing it's kind of random still.
Yeah. I think we have to be careful and understand the nature of the symptoms a bit more.
Okay.
I couldn't really get this from the poster. I think some of the patients are going to have chronic bronchitis.
Yep.
And maybe this is, if you like, healthy smokers with some inflamed airways, with chronic sputum production, but without breathlessness. And there aren't really good treatments for sputum production. So maybe if these people are being treated with bronchodilators, it's going to be a failed treatment. I think the group that's of more interest is those that are actually breathless.
Yes.
And finding out what the cause of their breathlessness is. Is it concurrent heart failure? Is it actually small airway disease? And there, I think that's interesting, and whether a bronchodilator would work in that scenario.
So I think from the phenotype stuff, we're talking in general terms about steroid responsiveness, about eosinophils a little bit, and then these others. Would you propose for the ordinary working chest physician out there, although we can't answer the question just yet what to do, that we need to be a bit more sophisticated with our assessment of these people at an early stage as possible, and what would you propose?
Yeah. So I think in general, and certainly in primary care, the gold diagnosis algorithm for COPD for most people holds true. So you need to have the symptoms, you need to have the exposure, and then it's confirmed with spirometry. We all know the CANCOLD study. There was more data at the ATS about the CANCOLD study. But the flaw in the CANCOLD study is that the symptoms were not necessary to have diagnosis of COPD. You essentially, you're a smoker, you have abnormal spirometry, and it's diagnosed as COPD. In general, you go for that triad. I think that's the way to go forward. But you asked me the question about the working chest physician. I think you can go a step further, and you can start to put labels on it in situations where that triad doesn't work, like those spiromics patients. Mm-hmm. So if you then investigate the patient, and you find CT, for example, CT evidence of emphysema, the patient has a low gas transfer factor, their spirometry is normal and their breathlessness, I would be tempted to call that early COPD on a practical basis, because they're breathless and you found emphysema, and go forward.
Yes, and so treating those people, this was a theme of last year's ATS, not this one, which was going to be about reactivation, keeping them going again, stopping them smoking, doing all those other things we should do simply at the beginning. Yeah. But they have exacerbations as well, which is a tricky one. But then
so I think then you work through that as you would work through most cases of exacerbation. So and work out what the causes are. Do they have colonizing bacteria, etc.? Do they need more bronchodilators?
And that would be sensible. Before we move on, one last thing I want to ask you about the FLAME study and also this exacerbation thing in COPD. Yeah. It seems there's a baseline level of exacerbations, and you were saying Salford had a very high baseline level, others about one, just under one, that really is very hard to stop happening. It seems to happen. Steroids have an effect in the eosinophilics to push them down to the baseline. Yeah. What do you think that might be about?
Yeah, so we're referring only here to those patients who are frequent exacerbators, obviously. So they're in those clinical trials where after successful steroid treatment in patients who are eosinophilic, you still on average see a baseline level of exacerbations of about 0.8, 0.9. So my feeling about this is, even though you have eosinophilic inflammation, you still have the other components of the innate immune response. And once you've successfully treated the eosinophilic inflammation, you still have the increased airway remodeling, the dysfunctional macrophages, more neutrophils, potentially bacteria on board in some patients. And so you need other therapies for that. So even in eosinophilic COPD patients, anti-eosinophil therapy is unlikely to be completely successful, because it's only a component of the disease.
I was going to ask you, do you think the current evidence on the biologics which we have, which are generally anti-IL-5, anti-eosinophilic strategies, are they going to have a role in the other people as well?
I'm optimistic about anti-IL-5 therapy in COPD. I think it will have an effect. Some of the data we've seen already, it does have an effect, but I think we need to look to high thresholds of eosinophils to maximise that. So I don't think we should be thinking about this sort of treatment in the patients whose eosinophil counts are 150, 200. I think we're at the higher levels.
So we've got to go looking for maybe something else which is against this background level of exacerbations, and exacerbation specific treatment maybe.
Yeah. Well, I think that one of the big missing bits of the puzzle is the bacterial colonization and how it drives the innate immune system. So there seems to be an inverse relationship between the degree of eosinophilic inflammation and bacterial colonization. And that makes sense when we think about what we know about sepsis. As soon as you have bacterial sepsis, your eosinophil count goes down. So once you've treated eosinophilic inflammation, you're still going to be left with this amplified innate immunity and bacteria. Yeah.
Before we move on, we've got a couple of questions online to pick up on. So someone's asked, and I asked about dose. Is there a difference in the steroids and COPD? Is there a difference in pneumonia signal between the steroids or other side effect profiles between any of the steroids that we use in combinations in COPD?
In general, most of the steroids have shown a pneumonia signal. Certainly all of those in the recent studies have, except I did mention the Summit study, and that was done in a different population. So I think this pneumonia signal is intrinsically dependent on who you study and how carefully you look for it, because the recent studies have looked for it very, very carefully.
Yes, I agree.
I think there's another point though, that when you look in when you think about real life practice, because there's a background pneumonia rate anyway, I think you've got to be careful about placing a patient on an inhaled steroid to have a pneumonia event, and then you say, it's the steroid, because it may have been a naturally occurring event. Yeah. So just my personal practice, I would not worry about this pneumonia signal in a patient on an inhaled steroid until the second event, because patients might get one anyway. But that's not evidence-based. That's just what I do. We could do.
Well, I do, and again, I think the story about pneumonia in COPD is a very complicated one, because again, when people have looked closely, there's never been a mortality signal, an outcome signal, and that's not pneumonia as I recognise it, and certainly not in elderly COPD patients who are vulnerable. So I think there's more to this than meets the eye. The other question we've got, Dave, was there any signals from the treatments we saw in COPD at this conference on mortality as yet?
I didn't see anything. I don't know whether you did.
Only in past, only from a point of view that actually people were making the assumption that I saw a few comments. If we reduce exacerbations, this will lead to a reduction in mortality as a secondary gain, sort of thing, and that's probably likely. But no one showed a signal. No one showed a clear signal.
No, I didn't see anything. I agree with you. And one of the problems with the COPD randomised clinical trials is the noise that you have. Patients in the active arm and the placebo arm, whatever the intervention is, they're older populations, they're dying of other things to do with aging and other things to do with smoking. And so it is actually quite difficult to get a pneumonia, to get a mortality
and that's
signal.
Worth briefly touching upon. There were a couple of sessions as well in COPD, and people are getting very interested in the comorbidity. Summit, for example, is a great example of a study which took comorbidities as a clear starting point, really. Any data that grabbed you from the comorbidity point of view, or any points you'd like to make?
I mentioned the Salford lung study earlier, and the high rate of comorbidities. I didn't see anything. I didn't see anything else in terms of the impact on comorbidities. But it would be quite interesting if we were to look a little bit more widely in COPD and try and bring in more actively treatments for comorbidities, because I think we as chest physicians tend to treat the lung, and then maybe we don't treat the comorbidities as aggressively as we treat the lung. Okay,
and I would, as a chest physician, I would bounce that back and say, I think other groups were guilty as well, and cardiologists need to look at the lung disease too sometimes, because there's some really nice associations between cardiac risk and FEV1 actually. So I think it works both ways, but I totally agree with you. I think we have to consider the whole I hate to use this word, but comorbidome, as people are now calling it, with associations, and we're understanding more. So there's a lot more to come on that. Are there any other sort of miscellaneous things you picked out that you'd want to share with the rest of the world that you picked up at the ATS on COPD?
Yeah, there were some posters on phenotyping, and we've been interested in phenotyping for a decade. And phenotyping really is a way of grouping patients. So although 10 years ago, when we started trying to do this, we thought it was an individual approach, it actually isn't, because what you try and do is you try and make some clusters and say, there's one group of patients, there's another. So, for example, here are the frequent exacerbators, here are the emphysema patients. But patients don't fit these nice boxes. You're trying to force them in. And they often have multiple features. So the few posters I saw actually tried to phenotype, and they came to the same conclusion, that some of the patients didn't nicely fit these boxes. So I think we need to give up with phenotyping.
That's controversial.
Yeah, well, because it's not an individual approach. It might make nice papers, but it's not an individual approach. I favour much more the concept of the treatable traits, where you take a characteristic and you treat that characteristic. Yeah. And that's actually what we do now anyway, because you take the frequent exacerbated characteristic and you say, I will try and treat that. You don't worry about the rest of it, just for that treatment. And we've had the discussion about eosinophils. So you frequent exacerbator plus eosinophils, I will treat that. Now that doesn't try and force the patient into a lump, into a sort of group. And then for that patient who is, say, frequent exacerbator with eosinophilia, you can then pick any other characteristics you need, say muscle wasting, and you treat that. So I think that this very much held through for the trying to lump people into the ACOS category.
Yes.
And I don't think that's helpful. I think you need to split ACOS up into individual disease labels and then treat accordingly.
And I think that it was palpable at this conference that the amount of information about ACOS and the buzz about ACO, whatever you're going to call it, was much less than last year. And clearly people are saying, actually, hold on a minute, this isn't a distinct syndrome on itself. It's actually just some different traits that we can find in both those groups of patients, both COPD and asthma in the old way. So I think that's absolutely true. As we move on, we've been asked to kind of certainly talk about treating bronchodilators and LABA ICSs in asthma and COPD. Is there anything else you want to say about the inhalers usage, the actual bronchodilators or combinations? Any other practical points?
There was, maybe not directly to us, actually, there was one other clinical trial that I found interesting, and you've asked about bronchodilators, and that was the Activate study. And this was dual bronchodilator therapy versus placebo over 8 weeks. It was actinium formoterol, and the first 4 weeks was, if you like, a standard exercise study. But what was interesting in it was it had steps per day. So in exercise studies, we often use artificial measurements, put them on an exercise bike to a shuttle water. This had steps per day, and that was interesting, and there was a boost in the natural steps per day patients did. And that's obviously a much more real world measure. And then the second bit, from 4 to 8 weeks, you carried on with the treatment, but then you had a behavioural intervention, and it was delivered through an electronic
platform.
So I can't remember whether it was text messages or something. Now that didn't have any further effect, and that gets me thinking, along with other things that we know about, that the patients actually then need some physical training. Because I think once you've got that bronchodilator effect, the patients are able to walk more. To get the further boost, even with the motivational training, the patients need to be stronger. So I think that they're in a good place for some of them. If they were to do some muscle training and actually have stronger muscles, they could go further. That may be putting all those bits of the jigsaw together: good bronchodilators, good motivation, stronger muscles. That's what you need.
And that we had a question asked about when you're looking at outcomes from bronchodilators, are we looking at activity or a measure of physiology, inspiratory capacity, or hyperinflation?
Yeah.
That kind of links into that a bit.
Yeah, and all of those were measured in this study. So the hyperinflation got better.
Yep.
But I think the key for me, the nice thing there was the steps per day, because the real life measure. And if you do those bits I said, would it go even further? And I don't think I've seen a study like that.
I think you're absolutely correct. I think it goes back to early disease as well. If we're trying to intervene with early disease where people are breathless, we want to try and stop them becoming more breathless and becoming more deconditioned, and that exercise is really important. They're not interested in inspiratory capacity. They want to be able to exercise more, not be breathless. And what you're really saying is that we should optimize bronchodilation to then go on and optimize the rehab. Which I think is absolutely critical. Which is really clear. I mean, going on to asthma a little bit, I think there was obviously quite a lot on LABA-ICS and also combination treatments, as well as adding some LAMA sometimes. And in many cases, all we showed was what we know, was that LABA-ICS worked very well in asthma, extremely effective at reducing exacerbation rates, extremely effective at improving lung function and improving symptoms. And people apply different approaches such that once daily treatment with the right long-acting compounds was as effective as twice daily, as long as you took them. And I think that's going back to adherence is absolutely critical. So that's key. And I think the other thing that there was one other poster in asthma talking about treatment of asthma with standard therapies, which was really nice, was looking at mild to moderate asthmatics and comparing PRN LABA-ICS used with formoterol budesonide versus regular ICS, which would have been the standard of care, stage 2 in the British guidelines, standard steroid therapy, which showed that if people just took PRN LABA-ICS, they had the same or better levels of asthma control, good levels of same levels of exacerbations. They did that with lower ICS dosage. But interestingly, when you measured their FeNO, their exhaled nitric oxide, they had a higher level of FeNO. So again, in other terms, they would have had some airways inflammation. And I guess it does show that we can use lower doses of LABA-ICS to help the patient and without worrying too much about some of that airway inflammation, or would you be worried about the airway inflammation?
Yeah, it's interesting. I think it comes down to understanding what it is that exhaled nitric oxide is telling us about the patient. So I agree that in patients with more severe disease, that exhaled nitric oxide is either an inflammatory marker or a marker of whether you're taking your inhaled steroids, but you start to worry more about it being an inflammatory marker. If you take the example of steroid-naive asthma patients, they have high FeNO, mild patients, good lung function, few symptoms, it's a marker of gene transcription of inducible nitric oxide synthase, but the patient's well controlled and so what? So I think in that instance, the patient's well controlled, they're not taking inhaled steroids, their FeNO is going to be up. But it doesn't mean they have excessive levels of airway inflammation. It's just a marker of the transcription of the gene that makes nitric oxide.
So it proves, certainly the rationale you put there proves that we can use a smart approach, or what patients do, which is often take their drugs intermittently in asthma, and as long as they're getting the symptomatic benefit, as long as they're not having attacks, that's okay. That's fine, which I think is really important. And I'll come back a bit to FeNO and another way of using it perhaps in a moment.
But I would just sound a note of caution that is for those patients at that milder end.
Yes.
As you get further on, I think it then is much more of an inflammatory marker.
Okay. So we're going to move on to asthma and have a little discussion now about some asthma therapies. And I think the asthma is beginning to move forward again with the phenotyping approach. Certainly has always been there a little bit in asthma, but even cleverer phenotyping now. But also the treatable trait approach is getting clearly into there with different achievable outcomes and setting different goals, as we just discussed in those people, perhaps with FeNO as well. what did I find useful? Certainly, as we said about Pheno, there was a very nice paper poster which showed that Pheno is extremely useful in predicting potentially response to inhaled steroids in some groups of people. But interestingly, in the elderly, these are proper elderly asthmatics. These were patients who had asthma all of their lives, who still had still had normal lung function, but with bronchoconstriction capacity, also bronchodilator responses. They had a much more variable Pheno level, and it didn't predict their response, but it did certainly predict their adherence. So going back to what you just said about Pheno, really, if you're taking your steroid, you suppress your INOS production. And it's the steroid which then does the work on the asthma, but you don't necessarily make a link between the nitric oxide and the effect on asthma inflammation.
So the reason why I said note of caution, because then in some situations, the patient's taking the steroids, their nitric oxide is still high, and it may be due to a certain type of inflammation, such as IL-13 driven inflammation.
Yes.
And that certainly drives nitric oxide synthase, and that, for example, is the rationale for IL-13 intervention in moderate to severe asthma, taking their inhaled steroids with high nitric oxide.
Which would work. Another, going back to phenotypes asthma, another, I thought a small but quite stunning piece of work, and it's one of my pet things, is the association between bad asthma and gastroesophageal reflux disease. I personally do not feel that you can make a patient happy with bad asthma if they've got persistent reflux disease. And there was a paper from Arizona which showed quite clearly that in a steroid dependent group of severe asthmatics who had severe reflux disease, the group that had Nissen fundoplication and actually had their problems solved had a dramatic reduction in their steroid requirements. Which because the guidelines British guidelines don't necessarily support the comorbidity of reflux disease and asthma, and I think it's significant.
I think it's there,
and I would do it. I think it's a small thing to pick up on. The other thing I picked up on phenotypes with asthma, and again, comorbidities, was that of anxiety and depression, in that we all know that bad asthma can make people depressed and anxious, and that's clear. But also that we are understanding now that has a measurable effect on inflammation, on bronchodilator response, with raised levels of TNF alpha and raised levels of interferon gamma, which again might drive a different inflammatory process in these people. And these people with significant levels of anxiety and depression had poorer bronchodilator responses, so less treatable asthma in some ways.
I think that's an interesting association, though, isn't it? And which way round that works. That because you have higher innate immunity, you then have worse disease and are more depressed, and
because of
which will work.
So it could work both ways. It would work both ways, yes. And again, it's something which I get, and we got to show by intervening, either treating the inflammation or treating the depression. We also know that cognitive behavioural therapy improves asthma control. Is that a well-being thing? Is it an inflammation thing? I don't know. It doesn't matter if they get better, which is important. Okay, we've got a question about sleep and bronchodilators. Did you say about sleep and bronchodilators at all at the conference, either in COPD or
I didn't see anything.
There was one or two.
There
was one or two things just to comment on sleep and COPD overlap. Again, showing that it's there. It's a significant morbidity. Not sure there was. I can't remember. I don't think there was anything about treatment of it. But certainly the message I took home from the poster I saw on sleep was, as chest physicians, we need to be aware of the comorbidity and look for it and diagnose these people, which I think is very fair, and treat these people, which is right. And there was a group of people who had airways obstruction, who sounded like they had sleep apnea, but once you solved airways obstruction, they didn't have sleep apnea, but they weren't properly studied. Okay. The other thing I picked up on from asthma was about some of the unmet need stuff, was about taking some COPD ideas, that actually people who have exacerbations in asthma seem to consistently have those exacerbations and have more of them. So we know in COPD probably the biggest predictor of future exacerbation risk is previous exacerbation behaviour, but it seems to be very tight in asthma as well. And there seem to be, which I wasn't particularly aware of before, apart from on a severity basis, but actually there seems to be an exacerbator phenotype in asthma now, which may require more intensive therapy and may hint at people who maybe get biologics as well going forward, who you can't stop their exacerbations on a high dose of inhaled steroids. And we see those people all the time, I guess.
Yeah, and I think both in asthma and in COPD, the targeted biological therapy or other therapy needs to go at the underlying reason for those recurrent exacerbations, right, of which there's probably quite a few. I think that's the key. So just staying on asthma, you probably have, except as one cause, excessive eosinophilic inflammation. Then there might be excessive allergic inflammation, and they're not necessarily the same things. And then you may have excessive innate or T1 inflammation. So these will all need separate targeted therapies.
Yeah, or even perhaps a combination of them, which would be even more interesting.
Yeah.
I think the other thing that somewhat surprised me, and again, perhaps it's my naivety of underestimating asthma exacerbations, was that in two of the really large biologic studies looking at the placebo arms, the impact of exacerbations on patients' quality of life was absolutely massive. Yeah. So that for every exacerbation they had, they lost 2.5 points of SGRQ, St. George's Respiratory Questionnaire, which is a big chunk of quality of life. And if you had two of those, you're going to be way past the minimal clinically important difference. So maybe we should take those events perhaps more seriously, as well as the mortality figures.
And certainly in COPD, that's well documented, and the slow recovery of the SGRQ is well known. I don't know whether those asthma posters showed that as well.
I didn't see that analysis. This was just a baseline before and after. Yeah. Whether there is, I think they probably will produce with a Daricard approach a recovery time, and we know that it sometimes takes 6 weeks in asthma as well as COPD to recover fully from an inflammatory point of view. But do they recover? And I think so.
In the COPD literature, I think that there's more convincing evidence that with viral infection, that's where you get those prolonged events. And I suspect something similar is probably happening in asthma as well.
Okay. No, so I was surprised by that, and I thought we needed to get onto that and actually really look hard. And it would be, from my point of view, more of a justification for the use of add-on therapy, i.e. biologics, or even perhaps it's in asthma, even then perhaps when you get to moderate doses of inhaled steroids and there is no steroid response, should you go for a biologic before you try oral steroids, which have massive morbidity and problems, which I think is reasonable, actually. Let's talk about biologics. There was quite a lot on anti-IL-5 therapy, particularly in asthma. There's been an explosion of outcomes and of studies that have looked into this. What did I think? I mean, again, it comes back to the eosinophil story as well, and we can talk about that more. I think we should throw that in together. And we've had a question also about eosinophils, about whether the outcomes of the eosinophil pro-con debate. But it seemed very clear that in steroid dependent or high steroid use, uncontrolled asthma, those people with eosinophils got a significant response to anti-IL-5 therapy with biologics given over a 6-month to 1 year period, both in quality of life, lung function, and also in exacerbation rate. It seemed to work. Any thoughts on that?
It makes sense to me that in both asthma and COPD, we'll stick with asthma for a second, but this should work. And the only question now really is, what's the threshold for number of exacerbations and eosinophil count that would help you pick the right patient?
Yeah.
So I think this comes then to the relationship between the blood eosinophil count and the number of eosinophils in the lungs. And there's certainly more of a chance of the patient having excessive lung eosinophilia with the higher blood eosinophil count you choose. And I personally can't really see the logic of using a low blood eosinophil threshold to pick a patient for a biologic, unless you have evidence from a sputum sample or bronchial biopsy of lung eosinophilia.
Which we do sometimes see in asthma. And
There
again,
can be a disconnect.
where there's a level there, that would be very hard to quantify, which is important. But it's certainly in people with eosinophils, the median number was 350 in one of the big American studies of over 550 patients, the Muscat study. That showed nicely that there was a 60% response rate to anti-IL-5 therapy, which is a positive thing. And is it worth the money? The other thing, which I thought was lovely, going back to your comment on real life, there was a reel from the west coast of America. What they've done is take a real life approach to looking at anti-IL-5, and in a small group of people, 30 patients who had eosinophil count greater than 300 in blood eosinophils, looked at who responded. And it seemed that about a third of the patients responded well. Out of 30 people, 12 responded, did nothing, 10 responded intermediately, and 8 responded very well, which I guess comes back to what we might expect in the future.
Yeah, I think it raises a practical issue of how once you've selected the patient, how you monitor them, and how you, within a limited healthcare system, limited resource, you say, yes, it's worked, carry on, no, it hasn't worked, stop.
And that would be, and if we can get a clear go, no go signal on these things, that would really help us and help our clinicians, help our payers know how to respond to that. There was another slight aside, but I think it is important to try and understand the nature of the biologics. There was a very interesting study which looked at eosinophilic granulomatosis with a Churg-Strauss vasculitis syndrome. And there was a buzz about this paper, this poster, because people were saying, oh, it didn't work. And actually, or didn't work very well. And I looked at this and I thought, actually, this is a really difficult disease. And it was a comparison of steroid therapy versus biologic therapy, and could you, with the anti-IL-5 therapy, bring the steroid doses down in this difficult disease? And 35% of the people, as I remember, got their steroids right down with the biologic therapy, as opposed to very, very few in the control arm. This shows that this is a hard disease, and I think this is obviously clearly a different process or a different driver going on that's not very steroid responsive, that's not very anti-IL-5 responsive, but is maybe worth a try in these very hard to reach patients, hard to treat patients.
Yeah, it is a different disease, and maybe some of the differences in mechanisms of anti-IL-5 therapies, and actually the differences between the drugs might have some effect there, targeting IL-5 or the receptor. But then eosinophilic activation is not only IL-5 dependent. No. There are other cytokines and chemokines involved.
And the other thing, going back to the drugs, I think it's going to be very, very interesting when we look at the differences between the drugs we have available, because they do work in different ways. They have different profiles of action. There was one of the posters at the ATS showed that reslizumab, one of the treatments, lowered eosinophil counts, but did not absolutely abolish them in the blood. Did it quickly, 2 or 3 days, but lowered them down to somewhere around 0.1, 0.8, 0.08 rather, so 86, 90 cells. Whereas we would hope that some of the other biologics available may absolutely reduce those eosinophils to 0.
And then to state the obvious, that will be okay in most countries, but then in countries where parasites are around, there has to be some.
And there's lots of things. We've got a question here about, again, going back to, we're talking a lot about eosinophils. It was the big topic. There was a hot topic discussion about using blood eosinophils as a target for COPD. I think treatable trait approaches, what I've said already, applies equally to asthma, or eosinophilic airways disease with asthma as well. Where do you stand on that debate that was held between Ian Pivord and Klaus Rabe?
It was an entertaining debate, very entertaining. Ian gave a very logical flow through how eosinophils could be used and the rationale. And Klaus mentioned a few items that actually came up in poster sessions as well, Well, one was the reliability of a blood eosinophil count, and he actually quoted one of my papers, sadly, which showed that there is some variation over time in blood eosinophil counts. Klaus correctly pointed out that some of the studies have failed to show a lack of relationship between blood eosinophils and the exacerbation rate, and then he used the term eosinophilia and provocatively said that, well, not many, it's only a small proportion of COPD patients who have eosinophilia. Ian had a very robust response. The reliability, he argued that, yes, there is some variation, but the variability is exactly the same as blood cholesterol. He said, nothing's perfect. You can attack this, but it's the same as blood cholesterol. He sensibly said that it's just one piece of information, extra information that you can use in your clinical decision making in order to decide whether to give an inhaled steroid. So its lack of relationship to exacerbations in general populations doesn't really matter. The clinical trials show that at that point in time, despite some variability, it does predict the inhaled steroid effect. And interestingly, while we talk about the relationship to exacerbations, there were other posters at the ATS, many of which showed no relationship to exacerbations, but the biggest one, the Eclipse study, 2,000 patients, at a cutoff level of 300, there was a relationship. And much of the lack of relationship comes from smaller studies with lack of statistical power. So it was an entertaining.
And I think two other points. One, there was a very nice poster in asthma from New York where they looked at all of their asthmatics and measured their eosinophil counts and monitored them over a year. And so again, longitudinal data showing whether it changed or not. And it seems, this is going to state the obvious, that people had high eosinophils, stayed high, and didn't vary very much. People had low eosinophils, i.e. below 100 cells, stayed below 100 cells, and didn't vary very much. And then there were a group in the middle between 100 and 250 where they wobbled around. But that's humans, and that's biologic. That's the answer.
And that's the same as the study I was saying that I published that Klaus referred to. That's from Eclipse, and you get a group in the middle who wobble.
But I think it helps us because it shows us that we can be clear when we talk about biologics, whether we talk about steroid therapy, that we should treat the high people and not treat the low people, and maybe treat the people in the middle, depending upon maybe another trait that we can define or find, or something else which firms it up.
So I think certainly in COPD, that concept you've just said about a high, medium, and low group for inhaled steroids, I think that's a valuable concept instead of trying to just divide them in the middle conceptually in terms of drug response. And we have to remember that all drug responses are basically continuous variables, unless you have a genetic polymorphism where you might get an all or none response. What we're talking about here is continuous variables.
Yeah, absolutely right. And then the other thing which you mentioned in that debate, and I followed this through with a little bit more reading, was about terminology. And we must be quite strict about how we use the terms eosinophilia and the levels of eosinophils, because we are talking about levels in general which are within the normal range reported by laboratories. But interestingly, there was a paper published in 1976 in JAMA, which was a Harvard study where they looked at everyone in Harvard and the medical school who had blood counts done, and then they phenotyped them, asking about their atopy history and their nasal histories. And they found very clearly that if you took people who had no history of atopy, allergy, or nasal disease out of the cohort, out of the all blood count cohort, the normal eosinophil count in the non-atopic group, to be strict, dropped right the way down to below 100 cells. So I think we need to be very careful about how we use those terms, and I agree with you entirely. Using hard cutoffs is often not very useful. We have a question here, which I think we do need to clarify really quickly, about how we talk about biologics, about how long we should use a biologic asthma before determining whether it's worked or not. The answer to that question, as far as we know at the moment, is we do not know. And we need to be very clear about that. I think it's going to be very difficult because we're likely to have a continuum, as Dave said, of response. But if we can, to generate a clear continue or not continue signal. That almost certainly will not be based on exacerbations because the events will be probably too infrequent, and in the very frequent people it'll be too noisy, and it's going to be based upon either a marker of biological response such as blood eosinophil level or sputum, perhaps a sputum eosinophil level or biopsy even, perhaps going back to what you said about trafficking, as well as lung function response, although there was some data in asthma showing that lung function response can happen in people without raised blood eosinophil levels. So that may be difficult too. So I think we need to understand much more about that.
That lung function response in the milder, not the exacerbated.
Yeah.
I think that's probably linked to the role of eosinophils in airway remodeling. So eosinophils are able to lay down collagen, etc. And so if you resolve that part, I would expect an improvement in lung function. Yeah.
Okay, that'll be going to be a little bit controversial here then. Is that going to be worth treating, or do you think that's going to be we're using another big expensive sledgehammer to crack a little nut then with those people?
At this point, it's not going to be worth spending that money on that increment.
Okay.
Where probably you can achieve that through making patients adherent to their inhaled steroids in that milder population.
Okay. Well, we're coming to the end of this session. We've obviously enjoyed doing this. Dave, before we close, is there any other comments you want to make or any other highlights you want to draw attention to from this conference? Or what are you looking forward to for the next conference even maybe?
So from a COPD point of view, where we're certainly heading is towards a more individualized approach. And certainly the big debates were about inhaled steroid use, eosinophils, but we are essentially restricted to having three main classes of medicines: 2 bronchodilators and inhaled steroids. There's an advance in asthma in terms of anti-IL-5 therapy, and there's the hope of more in asthma. I think where COPD is now, the stage is set for personalised therapies. We need some tools to be able to take that step further.
And actually to key into that, which I agree entirely. And what are you hoping for the RS in Milan and next year's ATS? Are you anticipating any outcomes?
Well, I think so. So I'm not sure about those individualized therapies. I think what we will see in the next year is a lot of new data on the existing classes in patients who are frequent exacerbators. I mentioned the triple studies earlier versus dual bronchodilator. I think we'll be seeing that soon. I think there are some other studies going on with dual bronchodilators in patients who are frequent exacerbators. So I would expect the next year will be focused on that. I would hope that we continue the journey in terms of the earlier COPD patients. We talked about spiromics here, and I would hope we continue the journey about the greater understanding of biology, the innate immune system. I think we're well on the way to understanding eosinophilic inflammation in COPD. The other part is still much work to do.
And for me, before I close this, in asthma, I'm going to take two complete ends of the spectrum. The biologic end, absolutely. And those people who are clearly got the right responsive characteristics, eosinophils, exacerbations, treating them aggressively with biologics, hopefully will make sense, and we'll have evidence and data that will actually show that makes cost effectiveness sense, makes side effect of other drugs sense, and improves our patients dramatically. And then at the other end of the spectrum, I'm really excited about, you mentioned about this from Salford, and there was another paper as well which looked at adherence and ability to use inhalers, understanding why patients do take their treatment and why they don't take their treatment. Because clearly, for the mild to moderate asthmatics, well diagnosed, we have the tools to treat with lab or ICS therapy. We can use them in a variety of approaches. So how do we fit each approach, whether it's PRN use, whether it's smart therapy, whether it's regular therapy, to get the very best response from our patients? And do we get into the patient's mind to understand that adherence thing? And on that front, both in asthma and COPD, there are some very exciting new technologies coming forward with smartphone-based devices and you mentioned apps and things, which are going to really help us help our patients and get them to take their drugs better. So I hope you've enjoyed today. I hope you've enjoyed the last hour or so. We've enjoyed chatting, as always.
Yeah.
If you have any more questions, please do ping them in, and we'll try and answer them as it comes. And we would love your feedback as to whether this is useful. And we look forward to very much doing another session with you very soon.